Good morning, students. Here we are again. And I'm going to cover now chapter 29 on thought disorders. Okay? So let's jump right in. All right, so when we're talking about thought disorders, we look at primarily schizophrenia. There are also other thought disorders, but we'll look at schizophrenia primarily at this time. So, a thought disorder is described as a disorder or a disturbance rather in thinking, in reality orientation, and social involvement. How do people relate socially? Um, Thought disorders, we could also see disturbances or disorganization in behavior, in speech also. And we can almost feel like these individuals are alienated. They used to call it an alienated mind. Okay, and schizophrenia is a very complex disorder with multiple causes and multiple treatments. Okay, slide 4. So when we look at schizophrenia, we're talking about that disturbance in thinking, the way these people perceive things in the world, the way they perceive themselves internally is disturbed. It's off. It's not normal. All right. So they also have internal stimuli or internal experiences in the way that they process not only their own thoughts, but anything coming in. Sensory input can be disturbed also, uh, leading them to hallucinations and delusions. All right. We also see a flat affect. The affect, no expression, means flat, and the behavior can be unpredictable and very bizarre at times. And they are socially isolated. They don't really socialize with people. What is the cause of this? All right. So it is believed that there is overactivity in dopamine and underactivity or insufficient norepinephrine. And then, of course, early brain injury is also believed to be a cause. Now, like most disorders, I believe there's always a theory that's believed that it's genetic. And this one, in the multi-hit illness theory, it's believed to be genetic, and that when there are stressors in life, for example, brain injury at birth, a birth injury, malnutrition, any environmental stressor then triggers it. Okay, so that's the multi-hit illness, almost like the the oh, I had a brain fart. I'll be okay. Let's talk about the stress vulnerability model. That's on slide 7. All right, so it says that under the stress of biological or psychosocial factors, vulnerable people may be predisposed to a breakdown, thus the expression nervous breakdown. So they have just stress in their lives, which then just leads them to a breakdown. And, it just happens. Okay. We see poverty or major life change, divorce, college, substance abuse, something that brings them to this. All right, so what are the symptoms of schizophrenia? How do we diagnose this? So they have to have at least 6 months of symptoms from the 3 categories: disorganization, meaning disorganization in speech or behavior, or disorganized thoughts, the way that the individual talks. Now, since you're speaking is refers back to the way that you think, the way that you think is going to be generated in the way you speak. So if it's disorganized thinking, you're going to have disorganized speech. And then, of course, disorganized behaviors. So disorganized is one of the categories. Disorganized behavior, speech, etc. And then we have positive symptoms, okay? An area seen as the dimension, or rather seen as positive symptoms. So what are we talking about there? We're talking about, when you say positive, it means anything that's added to the individual, the personality. So when you have a hallucination, was the hallucination there before? No, it wasn't. It's added. So now we have hallucinations, that's added. So anything that's added, delusions, added, okay? Anything that's added is a positive symptom, okay? Anything that's taken away is a negative symptom. For example, alogia. Alogia is word or speech. So a without, alogia without speech. Person doesn't talk anymore. Positive or negative symptom? Right, negative. Avolition. Positive or negative symptom? Negative, right. A without, volition, will, no will. Anhedonia, without pleasure. Positive or negative? Right, negative, because it's without pleasure. Okay, so these are negative symptoms. So for 1 month, you should have 2 of these: bizarre delusions, hallucinations, disorganized speech, grossly disorganized or catatonic behavior, and negative behaviors. Okay, so you could have 2 of those. Now, only 1 symptom is needed if it is a bizarre delusion or hallucination. Then all you need is 1. If the person is just hallucinating or has some bizarre delusion, then you can have schizophrenia with just a delusion. Okay? All right. So, let's see. All right, so basically that's it. We know what a delusion is. That's a false fixed belief that a person has. Hallucination is an internal stimuli. It's usually a person will either see, hear, smell, taste, or maybe even touch things that aren't there. Okay? So, and disorganized speech, person says, I went to the ballpark to see a giraffe run around the bases while the elephant was at bat. I don't know, something like that. Very bizarre speech. And then disorganized behavior. Closely related to schizophrenia is schizophreniform disorder, okay? And this is at least 1 month, but less than 6 months of schizophrenia. So they call it a schizophreniform. It's like a form of schizophrenia. Schizoaffective disorder is schizophrenia, and then add major depression or mania or mixed episodes. So it's where you're going to see an affective disorder along with schizophrenia. Okay? And a delusional disorder is non-bizarre delusions involving situations that occur in real life, being followed, for example, that's a delusion that somebody's following you, the FBI. Being poisoned, somebody wants to poison you. Someone loves you, a famous movie star is in love with you. Having a disease, etc. Okay. Folie à toi or do. Oh no, that's not toi. That's a do. Folie à do is when you have two people with the same delusion. For example, the mother believes that the devil is in the attic, in the crawl space, in the roof. So now the daughter believes it also. So usually you treat the mother, you cure the mother of the delusion, and the daughter will be cured of the delusion. Um, so we talked about the three dimensions of schizophrenia. We said speech. That's and I mentioned before, because the way that you think is the way you speak. All right. So the neologism is when you form new words. Okay, that's on slide 10. You could take a quick look at that. Some of these you could look at on your own. And then we have the disorganized behavior, where the patient could be very bizarre and weird. I had a patient once that he would just stand in his room and rock back and forth, and if you try to speak to him, he wouldn't answer. You'd say, Ira, Ira, are you okay? And he would just keep rocking and rocking. And finally, after he would finish, you would then say, Ira, you everything okay? He says, yes, I was just working out the process. And so in his mind, this is the way that he worked out these internal stimuli that he was getting. And then you say, well, what happened? He says, well, I saw myself. I was able to see myself, and I had all these penises growing out of my body, out of my head and my legs. And probably a way of coping with his impotence, because the medications sometimes make you very impotent. So maybe he was dealing with that and other issues, and he felt in order to feel more empowered. This gentleman, by the way, tried to hang himself, killed himself, tried to commit suicide quite a few times. He once jumped off a bridge in the Central Park in New York and tried to hang him. So he had rope burns around his neck, where you could see that several attempts at hanging himself. Anyway, these patients can also, you can find them to be very unkempt, and they won't want to really bathe too often. Okay. All right. So slide 11, we have three dimensions of psychopathology and schizophrenia. We talked about the psychotic already dimension, the delusions. So the delusions could be delusions of persecution, of grandeur. You think you're too big. Persecution, somebody's after you. Somatic delusions, like the ones that Ira had, where he felt that there were penises growing out of his body. Or religious, that you're an angel sent from God. There is thought broadcasting, that you could broadcast your thoughts, or thought insertion, that people are trying to insert thoughts in your head, or withdrawal, that they're taking out thoughts. Okay, and then we have hallucinations, rooted in internal disturbances, and they can be so from the five senses. Just think of the five senses, and those will be the areas of hallucinations. Three dimensions of psychopathology and schizophrenia. We talked about continued rather. We talked about the negative dimensions. Check that on slide 12. And they'll have also poor hygiene. That's what's taken away. These are all the things that are taken away. And flat affect. Catatonic schizophrenia is basically a personal state in that. For example, if you're looking at slide 13 along with me, you'll see this woman in the wheelchair, and she can remain there for 2 or 3 hours in that position. And if you push her hand down, it will go down. If her hand is down and you pick it up, it'll stay up for 2-3 hours, and that could be a problem. It's called waxy flexibility. That's what that's called, when you can lift up the arm. All right, subtypes. means of schizophrenia. You have also paranoid schizophrenia. Of course, we have delusions of persecution or grandeur in these paranoid types. Disorganized. They're very, very disorganized. These type disorganized schizophrenia. Then catatonic, as I mentioned before. The catatonic type, they could be very rigid and they won't move in one position, okay? And they'll do posturing. They can, Also, you can see a patient with schizophrenia have very disorganized or bizarre behavior. All of a sudden, they'll start shooting their fingers up, and they know why they're doing it. There's some process that they're working out. Uses of antipsychotic drugs, that's what we use to manage any acute positive psychiatric symptoms. And we've talked about the antipsychotics in the past, and we know that we have the typical antipsychotics to treat hallucinations and delusions, the positive symptoms. These are the first ones that we came up with, and they were the only ones that were helpful in treating the symptoms, both positive, rather just the positive, but it just treated the positive. That was the issue with the typical. However, they carried a lot of extrapyramidal side effects. So that was the drawback. Like, remember we talked about dystonia, where you have the muscle spasms. The patient all of a sudden starts contracting and the eyes roll back, and you have also akathisia, where they can become severely restless and they can't sit down. They'll get up and start moving around. You also have pseudo-Parkinson symptoms. And then you have tardive dyskinesia, which is irreversible. And you can also have neuroleptic malignant syndrome. So these are the drawbacks of the typical antipsychotics. Some atypicals can cause it, even though they're really not supposed to, but some can. So we mentioned tardive dyskinesia. That's when there is lip smacking or neck twisting or face grimacing, chewing motions. Usually tardive is irreversible. What you want to do is just take that patient off that medication immediately. They could be tried on another medication, and then you would give like a anticholinergic drug to help with the side effects. Then we mentioned neuroleptic malignant syndrome, and there's muscle rigidity in this, altered consciousness, hyperpyrexia, labile pulse, blood pressure, and elevated creatinine phosphate. That was with neuroleptic malignant, and we talked about that before. Atypical antipsychotics, they relieve both positive and negative symptoms of schizophrenia, and they're less likely to cause extrapyramidal side effects. Medication used for side effects are, as I said, anticholinergics. They're used to treat dystonia and Parkinsonism, and they may reduce akathisia. Antihistamines, IM, for rapid relief of acute dystonia, usually work. Best one used is Benadryl, 25 to 150 milligrams. And then preventatively, we use Cogentin, 1 to 6 milligrams a day, or Artane, 5 to 15 milligrams daily. And then Ativan also helps a lot with these contractions and etc. Overall goal of treatment for schizophrenia is safety in all settings. You stabilize that patient on antipsychotics. You monitor definitely monitor the effects of the medication on the patient, and basically taking care of that patient for safety reasons. Safety is very important because these patients may want to injure themselves. Okay, so what are we trying to do? We want to decrease hallucinations, want to decrease delusions, we want to try to get these patients to be a little more social with one another, so we'll have them go to groups, and we want them to have a reality-based connection in reality. So basically, and also you want them to have a good mood and be happy with their treatment. Thank you so much. Talk to you again.